Hi guys, today I'm going to discuss about very important topic which is called as premature ejaculation. All the pictures in this video is just for understanding purpose. So let's start with the premature ejaculation, which is called as earlier or early ejaculation. This is the most common sexual disorder among the men younger than 40 years, with some studies suggested in the US population 30 to 70% of the males are affected at some degree in their lifetime. Premature ejaculation can be a lifelong or acquired. With a lifelong premature ejaculation, patient has experienced premature ejaculation since the first coitus. While acquired premature ejaculation, patient previously had successful sexual relationships and only developed premature ejaculation later on. What is the most common associated conditions? For example, some people have a previous psychological difficulties, some have early sexual experiences in their lifetime, family relationships during the childhood and adolescence can affect premature ejaculation. Poor relationships, work in the social, school, workplace can also contribute towards premature ejaculation. Patient characteristics in the cases of acquired premature ejaculation can include sometimes erectile dysfunction, performance anxiety, psychotropic drug use. Some of the patients with acquired premature ejaculation, you need to inquire about some of the following things like previous relationships, number second, current relationship, non-sexual aspects of current relationship, sexual partner's level of involvement in the treatment, impotence problems, capacity of the coitus, sexual context, sexual response of the partner. How we diagnose premature ejaculation? In males with a premature ejaculation and no other medical problems, no specific conventional laboratory test aid or affect the treatment. Checking the patient's level of serum testosterone and prolactin may be appropriate if premature ejaculation is observed in conjunction with the impotence problem. If depression or other conditions coexist, laboratory studies such specific to depression or other medical psychological problems should be appropriate. Other conditions that should be considered in making the diagnosis of premature ejaculation include severely delayed orgasm in the female partner. This is very important. Adverse effect of psychotropic drugs means people are taking antipsychotic medication can also affect presence of pre-ejaculate and erectile dysfunction. Little bit more about premature ejaculation, which is also referred as a rapid ejaculation. This is the most common problem in the younger population. Most of the professionals who treat premature ejaculation define this condition as the occurrence of ejaculation earlier than both the sexual partners wish. Let's we discuss one example, which is a very basic example and most important thing to understand. For example, a male may reach a climax after 8 minutes of sexual intercourse, but if his partner regularly climaxes in 5 minutes and both are satisfied with the timing, this is not a premature ejaculation. However, a male might delay his ejaculation for up to 20 minutes of sexual intercourse, but if his partner, even with the foreplay, requires 35 minutes of stimulation before reaching climax, he may still consider his ejaculation and subsequent loss of erection premature because his partner will not have been satisfied. Because many females are unable to reach climax at all with the vaginal intercourse, no matter how prolonged the second situation described may actually represent delayed orgasm in the female partner rather than premature ejaculation in the male. This is the most important thing. The problem can be either or both depending on the point of view. Such differences in perspective highlight the importance of obtaining a thorough sexual history. So both the partners, whenever visit the physician, this is important thing. Premature ejaculation may be a lifelong or acquired. Lifelong premature ejaculation applies to individuals who have had the condition since they become capable of functionally sexually active. However, acquired premature ejaculation means that the condition began in an individual who previously experienced an acceptable level of ejaculatory control and later on having some issues, so experiencing premature ejaculation. There are some diagnostic criteria which were published in International Society for Sexual Medicine in 2014, which describe number one, ejaculation that always or nearly always occurs before or within about 1 minute of vaginal penetration from the first sexual experience, or clinically significant and bothersome reduction in the latency time, often to about 3 minutes or less. Number two, inability to delay the ejaculation on all or nearly all vaginal penetrations. Number three, negative personal consequences such as distress, bother, frustration, and avoidance of sexual intimacy. So, what is the pathophysiology? Premature ejaculation is believed to be a psychological problem and does not represent any known organic disease involving the male reproductive tract or any known lesions in the brain or nervous system. The organ systems directly affected by premature ejaculation include following: male reproductive tract, which include penis, prostate, spinal vesicles, testicles, portions of central, peripheral nervous system, and reproductive organ systems of sexual partner. Perhaps the most pronounced effect of the premature ejaculation, however, is a psychological. Both partners are likely to be dissatisfied emotionally and physically. Attempted pregnancy is a particular concern if the premature ejaculation is so severe that it happens before commencement of a sexual intercourse. Conception will not be possible unless artificial insemination is used. Some have questions whether premature ejaculation is purely psychological. A number of investigators have found differences in nerve conductions, latency times, and hormonal differences in men who experience premature ejaculation. Research published in the Chinese Andrology Journal showed that semen from a man with a premature ejaculation contained significantly less acid phosphatase and alpha glucosidase than did the semen of controlled population. Researchers concluded that these biochemical parameters may reflect dysfunction of the prostate and epididymis, possibly contributing to premature ejaculation. Psychological factors have been found to contribute greatly to premature ejaculation beyond merely reducing the time to ejaculation. However, whereas patients with a premature ejaculation show significantly lower intravaginal ejaculator latency time. One psychological explanation of premature ejaculation is that males are conditioned by societal pressures to reach climax quickly because of fear of a discovery when masturbating as a teenagers or during early sexual experiences with the others. This pattern of a rapid attainment of a sexual release is difficult to change in marital or long-term relationships. The increasing acknowledgement that female arousal and orgasm require more time than the male arousal may lead to increased recognition and the definition of premature ejaculation as a problem. It has been theorized that evolutionary factors are involved. From an evolutionary perspective, it seems logical that males who can ejaculate rapidly might be more likely to fertilize a female than those who require prolonged stimulation to reach climax. The genes of a male who ejaculate rapidly would be more likely to be passed on. In some settings, a male who could not complete the fertilization process experiencing premature ejaculation. In United States, an estimated 30 to 70% of American males experiencing premature ejaculation. National Health and Social Life Survey indicates a prevalence of 30%, which is fairly steady through all adult age categories. However, in international statistics, estimates of premature ejaculation in European and Indian mirror the prevalence in the United States. The prevalence in other parts of Asia, Africa, Australia, elsewhere is not exactly known. Premature ejaculation can occur at virtually any age. As reported condition, it is most common in the men aged 18 to 30 years, but may also occur in 45 to 65 years. A telephone survey of 1,300 men without erectile dysfunction found that premature ejaculation was reported by 21% of non-Hispanic African Americans, 29% of Hispanics, 16% of non-Hispanic whites. A small study of sexual health clinic in Australia, 59% of premature ejaculation diagnoses were in the men of Asian Middle Eastern descent. So let's talk about some treatment options. Medical treatment of premature ejaculation includes several options. Serious primary medical condition like a cardiac angina should be treated. In addition, any accompanying erection problems, erectile dysfunction should be treated. Various methods are available, so we can discuss one by one. Pharmacological therapy. Premature ejaculation that relates to erectile dysfunction may resolve if the erectile dysfunction is treated successfully. There is a desensitizing agents. Some of the creams, lotions, sprays one has to apply on the penis to decrease the vibratory threshold and help men with the premature ejaculation to delay their ejaculatory response. This preparation is not yet approved by FDA. Simple combination of lidocaine cream, related topical anesthetic agents can also be effective. Number second, selective serotonin reuptake inhibitors. The most effective pharmacological therapy for premature ejaculation is to administer a drug from the SSRI class. There are various SSRI drugs: sertraline, paroxetine, fluoxetine, citalopram, depoxetine. Optimal medical treatment regimen for the premature ejaculation has not been established. However, the experience has been that in some males, single dosing before sexual relations can work well, whereas in others it may be necessary to achieve or maintain a target blood level through daily use of a medication. Obviously, each medication has a side effect as well that should be discussed with nearby physician. Phosphodiesterase type 5 inhibitors. Some studies have demonstrated that combining phosphodiesterase type 5 inhibitors with SSRIs provide better results in the treatment of premature ejaculation than using SSRIs alone. The reason for this is unknown, but part of the explanation may be that improved, firmer, long-lasting, and both erection resulting from PDE5 inhibitor provides inhibition of ejaculation via downregulation of receptors involved in sensory latency times. In addition, a reduction in the performance anxiety may exist. Regardless of the mechanism, PDE5 inhibitors have been found to be safe and effective as a therapeutic adjunct for the premature ejaculation in men. Other agents, however, I have no personal experience for such, but tramadol medication which can be used in certain times. And any other opioid analgesics, as I told, tramadol was found to be significantly more effective than placebo in terms of increased time to ejaculation, increased sexual intercourse satisfaction, and tolerability. Now, this is as per a study in a randomized double-blind placebo-controlled clinical trial previously done. Counseling and sex therapy, this is the most important step. First step to attempt to relieve any underlying performance pressure on the male if premature ejaculation occurs when intercourse is attempted. The couple should be instructed not to attempt intercourse until the ejaculatory problem is treated. In the meantime, male may use manual stimulation and other sexual practices. If the male always experiences ejaculation with initial sexual excitement or early foreplay, this is a serious problem and probably indicates lifelong premature ejaculation. Such cases will most likely call for treatment in conjunction with the mental health. Sometimes surgical intervention can be used. So overall conclusion is different treatment options, sometime consultation with a sex therapist, a psychologist, and a psychiatrist may prove helpful if the primary care physician and urologist cannot provide successful treatment or does not have the time to explore psychological issues and implement behavioral techniques. Squeeze and pass. If the primary care physician, urologist is inexperienced, uncomfortable with the treating premature ejaculation, early referral to a sex therapist and psychologist should be attempted. Some physicians are comfortable implementing pharmacological therapy but not the behavior. As with any medical condition, the patient should be offered all available treatment options. For many men who may have a severe emotional disturbance underlying the premature ejaculation, referral to the mental health professional is the most appropriate. Some of the differential conditions which can be important to discuss here. One such condition is severely delayed orgasm in the female partner. This is the very important thing to be discussed. The term delayed is relative in the context. The average time to climax in the females varies, but averages 12 to 25 minutes according to many studies, and rarely 3 hours, which can be outside the normal circumstances. In the extreme cases of delayed or difficult orgasm in the female partner, almost any male would be considered to have a premature ejaculation. The partner's sexual response must always be taken into account. Another such condition is an adverse effect from a psychotropic drug. If the premature ejaculation is started in association with the commencement of any pharmacotherapy but ceased when the drug was withdrawn, should strongly consider a relationship between the two events. In addition, pre-ejaculate may be mistaken for a premature ejaculation. Pre-ejaculate is the lubricating fluid produced by Cowper glands and other glands during the excitement phase of sexual stimulation. A detailed sexual history should clarify this matter and enable the clinician to reassure the male as to what is actually happening. Erectile dysfunction may be associated with premature ejaculation, and it may be difficult or impossible to establish which condition developed first. For lifelong premature ejaculation, association with a certain anxiety disorders have been noted. For acquired premature ejaculation, associations with the drug, withdrawal, thyroid disease, prostatitis have been found. A study of men with chronic prostatitis, chronic pelvic pain syndrome found that odds ratio for the premature ejaculation significantly increased with the severity of pelvic pain. So this is very important. In males with premature ejaculation and no other medical problems, no specific conventional laboratory test aid affect treatment. If premature ejaculation is observed in conjunction with the impotence problem, it may be appropriate to check the serum testosterone level and prolactin level. Other laboratory studies, for example, checking thyroid functions for hyperthyroidism or hypothyroidism, can be mandatory. Some investigators are performing vibrational threshold testing on the volunteer subjects. Others are using nerve conduction times, somatosensory latency testing, or both. Few investigators are evaluating hypothalamic pituitary gonadal axis. Some are testing melatonin levels. Some are measuring levels of nitric oxide. At present, however, all such determinations must be considered experimental. So going further, thank you.